Hello everyone, my name is Amir, hematology registrar from Huddersfield, Royal Infirmary, UK. Welcome back in the hematology daily clips. Today we will talk about high INR again, but this time not in patients on warfarin. Sometimes we receive patients whose INR are high because of other reasons, not because of the warfarin. So as a hematology registrar or as a hematology consultant, you'll be receiving a lot of calls from the medical and surgical team mentioning that their patient is going for any surgery or any other procedure, but their INR is high and the patient is not on warfarin. What should we do that? Should we give the patient FFP or should we give the patient prothrombin complex concentrate? So one thing in mind, um, prothrombin complex concentrate is only to reverse the effect of warfarin, not to give in a patient who are not on warfarin and their INR is high. So if the patient is on warfarin and their INR is high and the patient is going for surgery in the next few hours, then yes, then you can give this patient PCC according to the INR. But if the patient is not on warfarin and their INR is high, then you should look for other causes of high INR in this patient and address that causes. So what are the other causes of high INR in the patient? Anything that affect the liver and affect the liver function, synthetic function, that can result in abnormality in the INR of the patient as well. Because liver secretes many coagulation factors, and based on the coagulation factors in the plasma level, your INR value is determined on testing. So if you have any liver insult, liver injury because of, for example, infection, alcohol-related, or metastasis, a disease to the liver, liver function is impaired, and you will see that the prothrombin time is high and the INR is high as well. If your patient is in severe infection or let's say in DIC, and those are the cases where liver function is impaired as well, and the INR is abnormal as well. So whenever the liver function is deranged because of infection, metastasis, alcoholic or non-alcoholic insult, then your INR will be affected. Vitamin K deficiency, it can happen in young population as well if they are if they have a disease, the colonic malabsorption disease or the ulcerative colitis or Crohn disease, which affect the colons or intestine, they can have impaired absorption of vitamin K as well. And vitamin K deficiency can lead to poor production of coagulation factors, and as a result, their INR will be affected as well. So, vitamin K deficiencies, we have mentioned infection, DIC, metastasis to the liver, any alcoholic related injury, or non-alcoholic liver diseases. They all can lead to abnormality in the INR. So in these cases, if the INR is high, it does not mean that you should give your patient prothrombin complex concentrate. Prothrombin complex concentrate is a very prothrombotic uh, product. It can lead to thrombosis in the patient as well if given in high concentration. That's why we always calculate the dose of prothrombin complex concentrate according to the INR of the patient if the patient is on warfarin. If the patient is not on warfarin and the patient INR is high, then vitamin K is the best choice. Give patient vitamin K, and check the INR in 4 to 6 hours again. Usually, the INR would come down to a normal range or to a range that you want for the procedure or surgery. Vitamin K effect usually shows itself in 4 to 6 hours. That's why we recommend in our trust to check the INR again after 6 hours of vitamin K injection. So give the patient vitamin K and recheck the INR. The INR uh, will be to a level for which you want surgery. Some of the hospital need INR below 1.5. Some hospital needs INR below 1.6. Some hospital need below INR 1.4 for any procedures or surgery. So whenever we receive call from other department and say that the INR is drained, it is usually 1.8, 1.9, 2.1, 2.0 like this. And for that INR, which is high because of the liver-related issue, not because the patient is on warfarin, you can give them vitamin K, up to you if you want to give 2 milligram, if you want to give 5 milligram or 10 milligram. I've seen gastro people, they have gone up to 20 milligram as well, but it is a respective clinical team decision. I always give 5 milligram or 2 milligram, not higher than that. Yes, if it is warfarin related bleeding issue, then I go up to 10 milligram. So the basic idea here is that INR can be high because of warfarin and because of other liver pathology as well. If warfarin is not involved, your patient does not need prothrombin complex concentrate, and your patient does not need FFP to reverse this high INR. The patient INR may be high because patient has hepatitis, patient has alcoholic related liver injury or non-alcoholic related liver injury. Patient may have any solid organ cancer and it has metastasized to the liver, and chronic patient may have chronic liver disease, etc. So in that cases, the liver function is impaired, and when the liver function is impaired, the PT, prothrombin time, INR, or APTT, they will all be deranged. You will see the bilirubin or the ALT or AST or ALP, they will all be deranged. So as a result, the INR will be deranged as well. So for the medical team and for the surgical team, when they contact the hematology team related to high INR, please check these things, whether the patient has any liver disease or not, if patient has any liver-related metastasis, if the background of the patient says patient has solid organ cancer, if the patient has any alcoholic liver disease history or not, if the patient has any sepsis or not, they all can lead to liver dysfunction, and INR can be high as well. But if you are not sure, or if you are a junior and don't know about what to do with this high INR, then yes, then you are welcome to contact hematology registrar or hematology consultant on call. But these are the questions that the hematology registrar or consultant will ask you, that whether your patient has any liver-related disease or not, any chronic liver disease, alcoholic liver disease, non-alcoholic liver disease, any metastasis, any infection or suspicion of DIC. And if these things are present in your patient, then yes, then these are the causes of high INR in the patient. In that case, you do not need any PCC for your patient or FFP for your patient. FFP, if you give to your patient and patient has chronic liver disease, you are increasing the portal vein pressure of the patient, and this can lead to bleeding in the patient, because portal venous pressure will increase because of the FFP. The FFP is all plasma, and the patient, chronic liver disease patient has varices, and they can bleed very easily. So we are very conscious about giving FFP to any patient, but it is a separate topic. Today's discussion is about high INR in a non-warfarinized patient. what to do with the high INR in such cases, and what questions we will expect from hematology consultant or registrar when we contact them for uh, high INR. So those hematology registrars who are in training or in residency job do not issue PCC. We have trust guidelines. If you are not sure, open the trust guidelines and say what it says. If not, open the National BSH, British Society of Hematology guideline, and say what is the recommendation about that. But the recommendations are no PCC for non-warfarinized patient with high INR. Reverse it with vitamin K, or address the cause, which is leading to high INR in the patient. Give them vitamin K. Some patients have vitamin K deficiency. Some patients have abnormal liver synthesis function because of the disease. So if you have any question about high INR, you can put in the comment. And those people who are in the FRC Path WhatsApp group, they can post a question over there, and I'm happy to answer. Thank you.